to orient you a little bit to some of the papers that you have, because
I figured out. That's important.
Yeah. Well, that's what I figured.
Can everybody hear me? Can you hear me? So, I have to say thank you for making all the effort to come from the four winds as far as Kazakhstan this month, Finland, let's see, what other countries? France. Not specifically for this meeting, but although we have a couple of people who hopefully will be joining us in a few minutes, I just want to point out before I start story time that we have some really great materials here that many of our volunteer physicians and other experts have helped us with, including the Metabolic Santa Clara County, which you've seen, and the recently updated coronary artery calcification brief, which was really complicated to do. But it was done with David Marin, the head of preventive cardiology here at Stanford, Joe Skye, the Air Force guy, our cardiologist from Travis Air Force Base, Bill Baumer from UC Davis, Matthew Budoff from UCLA, maybe I've forgotten some names, but a lot of course, Evelyn Stock from UCSF, Susan Ivey from UC Berkeley, and Brian Vaughn is the magician on the computer that can pull this all together and be a very wonderful diplomat while the cardiologists are arguing. So there have been many a late night pulling these materials together. And one of the wonderful things that we have, and maybe we'll distribute it later, is the article that came out on the front page of the Wall Street Journal this weekend, showing, thank you, Nirali, the map of cardiovascular disease for the country, and that we are having a bigger problem again. As I am hoping that our lost, a couple of our folks will join us, I just want to say that we have done 3 university best practices a month since January, and that upped our workload by a third by starting this one. But it's been really delightful. We are going to take July off. It's our summer holiday, and I'm going to take that time to be writing grants and really pulling back and doing some strategic planning, because throughout the year we will do 32 public meetings. So last week was Los Angeles on Monday. On Tuesday, Sacramento, California Department of Public Health. Then we got a confirmation from the U.S. Surgeon General's office on Thursday that they wanted to have a roundtable yesterday in Sacramento. So I had confirmed CEOs and CMOs for this private sector 2-hour roundtable with the Surgeon General, where the head of Million Hearts had requested that we do a special focused private sector meeting on cardiovascular disease. And it was extraordinary. I don't know how many of you have met Surgeon General Jerome Adams, but Joe Skye, the Air Force guy, was there with me, and he can attest to the fact that it was a pretty special experience. Do you want to say anything about it?
I think that the important things that he pointed out was that most of the answers need to come from outside of the healthcare system, and the focus was on the social determinants of health. And cardiovascular disease has reached a point where our national security is at stake with recruitment for the military, with retention, and that's just the military. Then you take in first responders and policemen, firefighters, these sorts of things. And then also his focus on the entire working population, that a country needs a sustainable amount of healthy people to be able to survive, and this becomes a national security issue. And so with that focus, the attention on cardiovascular disease was yesterday's challenge.
But it was a great opportunity to highlight our work because the Surgeon General tweeted out 600,000 followers photographs of the meeting and highlighted the issue of cardiovascular disease. So the timing just could not have been better to have the front page story this weekend in the Wall Street Journal. And our dear Sidney was quoted in it. So that was really, really good timing. And we are very, very lucky to have him with us today.
Yeah, I think the battery's down, so I'll just talk very loudly. But basically, Dr. Sidney is going to share with us so much about the CARDIA study and the impact of coronary artery calcium in the otherwise maybe not identified high-risk population. And so one of the missions of RightCare, of course, is how can we help the vulnerable, the 40 to 60 or maybe even younger age group that is not necessarily getting stamped with the heart disease prevention plan. And so before we start with your talk and the results of that great study, maybe we can, I think we do this every time, but it helps to get to know everyone. Just go around the room and share maybe a little bit about what you're hoping to learn today from both Dr. Sidney as well as Dr. Sky, who will talk a little bit about the military perspectives of cardiac calcium and their experience. So Emily, maybe you want to start us off?
Sure. So it's very timely that we are having this session today. I was very shocked by learning this weekend that one of my husband's co-workers, a 40-year-old young man, just married a year ago, was found dead by his wife coming back from a trip, and massive heart attack, just sudden death and devastating. And what you were saying, Joe, about the Surgeon General's concern is highly, highly important, and our workforce and our families and our whole society is at risk right now. So I think what I'm hoping is that we can somehow start thinking of ways of intervening now. You know, it's time to do it. So that's what I'm hoping.
I get a second chance.
Hey, you drove a long way to get here. And
I get to talk. I'm Joe Sky. I'm a cardiologist at Travis Air Force Base, and I have in the past couple of years learned that what I do in the office is not as important as I used to think it was. And so I spend a lot of my time convincing my patients that they should listen to themselves and other advice outside of the hospital. And then recently I've also started advising people to pay a lot more attention to where they live and to take these things into account, because we know it makes a difference on how long we live. And yesterday, I'll illustrate that point one more time with something the Surgeon General brought up, and someone told a local story. To play summer sports, to play baseball in Sacramento with one of the leagues is $1,000 now for kids just to play a summertime league. And I think football was $5,000 for the fall. And so many of maybe that price is adjusted for lifetime injury. But in any case, the availability of simple activities that were standard for our childhood are now priced out for many of our patients.
I'm Carl Long. I'm the director of the Prevention Center at USAF. Very interested in this whole process of how we risk stratify patients and what we tell them. And I think, I say this every day at least 3 or 4 times to patients about the importance importance of us helping them understand what a negative stress test really means, because it doesn't mean you don't have disease. And I think we fail to explain to them exactly what we're testing for when we do these things. In the same way, then, as much as I've become now a convert for coronary artery calcium, they also understand what is a zero calcium score. I talk about the stratification of values, but I'm a firm believer that it's either zero or it's not zero, and not whether or not it's 50 or 100 or 150 or 500. Obviously, we get concerned and start looking at where is it and for those high numbers. But for me, it's either zero or it's not zero. And even the zero discussion is, it doesn't mean that there's not a problem. It means that at this point in time, we weren't able to detect calcium in your coronary artery. There's still an event rate, albeit very, very, very low, but there's still an event rate to people with zero calcium.
Hi, I'm Angela Fong. I'm a registered dietitian. I work in the prevention center in Dr. Long and Dr. Stock. And I come with a nutrition lens. Certainly what we eat 3 times a day or more, or less, makes a really big impact on the trajectory of our lifestyles and how we manage our stress and how we sleep, and all these things really play together. So these are things that I counsel patients on in the clinic, and so I'm particularly interested in how this affects our younger population, because I think that they often get overlooked. We have a lot of stressful workers, and we have a lot of people who don't necessarily pay all that much attention to their lifestyle factors, because they think that those things don't really apply to them. And so I'm particularly interested in learning more about that.
Hi everyone, I'm Louisa Duran. I'm an endocrinologist practicing in the East Bay. I'm also involved as Vice Chair of the American Diabetes Association Community Leadership Board. Long-standing interest in preventative care. Wanted to be an OB/GYN initially, and which drove me to medical school, but then learning about all of the chronic diseases and complications and largely preventable diseases drove me to endocrinology. So I find that in clinic, I'm actually in a really neat space, because I get patients from all ages across the lifespan, and am able to really kind of make an impact in terms of getting folks started on proven therapies that have been shown to reduce cardiovascular disease and stroke. And so this talk is going to be really great, because certainly always try and educate younger folks on what more they can do, especially with the rising obesity epidemic. I'm even getting pediatricians sending their 17-year-olds to my clinic for early impaired fasting glucose, prediabetes, and really seeing the need to intervene at a much younger stage in people's lifespan. So thank you for having me here.
I'm Evelyn Michaud. I'm a medical liaison with Jensen. So I work in medical affairs, and I care a lot about clinical data, and what's really important about clinical data is always a so what. And Johnson & Johnson, we have a credo, and the first people we care about are patients and clinicians. So whatever we do, it's always going back to what can we bring to patients and to clinicians. So with what we have now and what we may have tomorrow. So whatever we are looking for, it's always with this perspective. So I was here for the first time last time, and I felt like I learned a lot, and this is really a group I want to learn even more from and bring back feedback in terms on how we can make things better just as soon as possible.
Hi, my name is Ed Hunter. I'm with Genentech. For the better part of 15 years, we've done, I think, a fairly good job of supporting the education community. And I think in the last 2 years, we've really started to focus on patients who are at high risk for stroke. And what can we do to help prevent stroke in those patients, and with some of the education that providers need as well as patients what they need. So this type of setting is always a good insight into that, provides more information.
I'm Jim Adams, a cardiologist in Marin, and long interest in calcium scanning when I first came out, and worked as medical director at Imatron for years and did my first calcium scan about 1990. And immediately saw the value of it to help screen patients, and been doing that ever since. And Bruce Brundage, and then I was learning CTA with Matt was a fellow, and worked with Matt. We teach people and doing that, educating people, and just wrote a chapter on coronary calcium scanning with Greg Thomas that we did or LSAT's book on stress testing and all about calcium scanning, the importance of that and stress testing. And in the book, it's referencing the cardio study when it came out. I think Jeff Carter was the first author, and I'm glad to see that you're trying to absorb it. So for the last year or so, I've been trying to understand what it is and recent updates. So I really look forward to hearing about how we use that to find people early. And like you say, a negative scan doesn't mean that you don't have disease. It just means that you don't have, advanced plaque right now. I agree with you, a little bit of calcium, it's like telling somebody, oh, you're a little bit pregnant, but don't worry about it, you'll be over at 9 months, or saying, oh, you got a touch of cancer, but it's just a little bit, don't worry about it. And I think that it's a powerful tool that I've been using for, almost 30 years now. And finally, glad to see the world catching up to saying, hey, this is, a powerful tool. I think in your thing, I try and get patients to watch the Widowmaker documentary. And the tragedy of that. Everyone's seen the Widowmaker. You should go on Netflix and look at the Widowmaker. 2015 it came out. There's some other movies that, mystery or thriller movie, but this is a documentary.
It's by the Irish Heart Foundation, right?
What's that?
It's from Ireland, and it's amazing.
Well, the woman who did it, but it's all about the history of calcium scanning. They interviewed all the people who've done it, and people that I've known and worked with for 30 years when it came out. And it's interspersed with these stories of people who have sudden cardiac events and the tragedy of it and how the clock is ticking and people are dying of it. So you get people to watch it, well, do I need a calcium scan? Yes, you do. Middle-aged men and postmenopausal women. That's what I've said, men beginning at the age of 40, women at the age of 50, or 5 years earlier, they have risk factors. And you start to find it. And so this is what I hear, how do you separate the herd, who do you scan, and what do you do, and what other risk characteristics to find that high risk group that we need to track. So that's my interest for a lot of decades, so I'm glad to be here.
I'm a woman over 50.
That's
what I'm hearing. My name's Arathi Prabhakar. My background is managing R&D organizations and venture capital. I was director of the National Institute of Standards and Technology in the 90s, and then more recently director of the Defense Advanced Research Projects Agency, DARPA, from 2012 to 17. In between, I spent a decade in early stage venture here in the Bay Area, and we moved home a couple of years ago, so I'm here in Palo Alto. I am now starting a nonprofit organization with the mission of conducting R&D programs to create new solutions and new approaches to some of society's most challenging problems. And one of the areas where we think there are plenty of challenges is healthcare, and in particular our concern, we come at it starting from the perspective of how do we have better health outcomes at a fraction of the cost, because we're very concerned about the cost burden on our economy. In particular today we are developing, my colleague and I are developing we're designing a new program that will be an R&D and a demonstration program, not just about writing basic research programs, but not fully deploying that, because we're going to try to do something that hasn't been done before. And our particular focus is on preventing chronic disease, but finding ways to prevent chronic disease that can scale potentially to the scale of how many people are at risk of chronic disease, which is over 100 million people in the United States today who either have or at risk or are at risk of diabetes and or hypertension. You all know better than I do. But so we're trying to think about that entire picture. I'm particularly interested in this, and I've been very grateful to have the chance to join you now for my second time to come. I am listening to get a sense of how those of you who are dealing with these issues every day, how are you thinking about prevention? What are we doing today? And then in particular, I'm also trying to get educated about, I think that we have some huge health equity issues, because the communities that are most at risk of many of these diseases are of course not the communities that also don't have ready access, they don't have an annual physician's visit, and they may not be part of the conventional system. So those are the perspectives I'm really listening for. Thank you.
Hi, my name is Adri Pilson. I am from SCIPA. I'm not an MD, but I manage the quality and risk department there.
What
Today,
is SCIPA?
SCIPA, Santa Clara County, IPA. I'm interested today in learning in things that can be done, preventative things, risk factors that can be done. We have more of an indirect touch with the patient, but we do touch, from pediatric all the way to Medicare members. So I am really interested in learning what can be done, things that we can use and implement in our group to be able to provide education, not only to the providers, but also to our members.
Very good. I'm Dave Abramson. I'm with a little company called Amarin. I joined them just before they presented a study called the Reduce It study, which is a very high concentration of EPA. We are 100% committed to trying to address residual CV risk. Very excited about the data. And prior to that, I spent 23 years at Merck helping develop the statins, the ARBs, and actually a few diabetes compounds in the clinical development area. The one thing that's really interesting is how small world this is. I mean, I've just, speaking to Jim, and when I first immigrated, I was working with all the folks doing EBCT, Imitron, and all the, and I actually, some of the people you quoted, I trained with them. The one thing, this is a wonderful opportunity for industry to kind of align with groups like this that are doing fabulous work. And we've only been to a few meetings now, Hattie, but this is really a very impressive organization in terms of its commitment to preventative disease. The final piece that I'll speak to that's relevant to the research we're doing, we have committed a great deal from a resource perspective to look at minorities and women. We feel that these are very underserved in clinical research studies. In our study, for instance, we had 27% women, but minorities accounted for 16%. And so we're working with different organizations. Kaiser, I was just speaking to Stephen, we're about to start a project with Kaiser in Southeast Asians. We hopefully will do a project with the DoD, looking at African Americans and Hispanics and women. But it is a really important issue in the pharmaceutical and biotech industry, is that all these studies are being done and we're simply not looking at the entire population who might benefit. So that's our commitment. Tiny little organization, we're happy to be part of this group. Thank you.
Where are you located?
In Bridgewater, New York, but I live in Southern California.
Great. I'm Tim Lee, and I'm a pediatrician. I've been with Paladin Medical Foundation or Sutter Health for the past 15 years. My interest is that, selfishly, number one, I'm wondering whether or not I should have a coronary calcium scan because my dad is a veteran and he went to the VA a few years ago and he had some abnormalities on his EKG, and last year he had bypass surgery and quadruple vessel disease. And so I'm grateful to the VA and the cardiologist that we were able to bring the grandkids back to his village in China. So again, I'm wondering whether or not I need a scan since I'm 45 years of age. But secondly, I've been involved in quality metrics and patient safety for our organization. I think Louisa's, what you talked about, I saw some patients over the weekend for a checkup, and one of my patients that I've seen since a baby, he's now 12 years of age, but had a body mass index at the 99th percentile. Both of his parents were well educated. The one is very successful at NASA, the other one's at Google, and the child's BMI is at the, again, 95th, 99th percentile. And just yesterday, his total cholesterol is greater than mine, and his total cholesterol is 250. And so I'm kind of wondering how, and I attended a lecture about talking about motivational interviewing, and I kind of went through that, deployed all those techniques on this family, but clearly that was a little bit beyond, what we really wanted to talk about. So kind of that point with this family, how do I engage this family? How do I kind of move forward and get them to work on this? What kind of small little things can we do to make sure that this child does not have something like cardiac events in this early adulthood?
We can jump back there. Oh, okay. So my name is Eino Vekonen, and I'm from Finland, as Hattie mentioned. I'm a specialist in anesthesiology and intensive care medicine, and that's what I do back home. But I'm here at UC Berkeley as a visiting scholar doing some healthcare organizational research. And Hattie invited me to come here, and as probably at least some of you know, in Finland there's a very high rate of cardiovascular disease, and we've done a lot of work fighting that, especially in the Northeast region. And so I'm very interested to hear how you are approaching this problem here.
Hi, Tatiana from Metabolic, and I'm on the technology side, so my background is working with CEO of Intel, IBM for many years on the intersection of technology and business processes, and all the topics relevant to me. My father didn't wake up one morning, and it was, heart-related stuff, so very relevant. We have, so I started my company when I was diagnosed with cancer, and again, working right now with Health and Human Services and every single top healthcare organization, whether it's payer, provider. We do a lot of stuff with the government, and just last week have been awarded by Health and Human Services as the top AI vendor. I've been recognized as Forbes 30 technology, women-run technologies Arab that makes a difference. So we have built models like you guys mentioned that take massive multi-dimensional data sets from socioeconomics, environmental, healthcare data, and we presented with the White House model where we can predict cancer types at the zip code level. So there's definitely hard evidence on dependencies on where you are and everything else. We just published a paper on, I'll give you exact title, a novel method for cardiac risk assessment using neural networks. And with all the companies, we basically deploy highly sophisticated algorithms and engagement models, so people can be influenced on the front end and physicians get tools to how to manage people in their conditions. So thrilled to be here. Thanks to you, I did get my heart's content. And and for me, I just, spoke at UN in Geneva and work with World Health Organization and other international kind of bodies. It's always interesting to get feed from all of you and see how that can be translated into solutions that impact people's lives.
Well, I'll be interested particularly in the findings in the coronary calcium that show all-cause mortality, including from cancer, is increased related to coronary calcium. So maybe you can start putting your antenna up on that. Okay. Yep, sorry to interrupt.
Oh yeah, just quickly, I'm a scientist. I'm currently a visiting research scholar at Berkeley, a storyteller, and a startup advisor. So just bringing my whole self to this project and really hoping to make an impact. We lost my uncle when he was 59.
Dr. Marin.
David Marin, I'm a cardiologist. My career is pretty much about primary and secondary prevention. And I remember Dr. Sidney when I came to be a fellow at the Stanford Prevention Research Center, where I'm now interim chief.
Bill has to work before we do that.
Oh, no kidding. Okay.
Yes, again, I think it's good for you. I think everyone has you. So, and I'm Nirali Bor. I'm a stroke faculty here and co-chair of the group that you had, including me in this when we started out in Silicon Valley. And I think it's pretty awesome. We started over 6 months ago, 6 meetings ago, talking about